or the improvement in early detection, we are going to have cases of DDH who are presenting to us late. And most of those cases require open reduction. And whenever we carry out surgery, always complications are going to be there. The complications of DDH are not simple complications because it affects the long-term outcome of patient. So today we are going to discuss the complications of that. And we are very fortunate to have 5 experts across the world with us for the interaction. The first one, the senior most, is Professor John Wedge from Canada. John Wedge's journey in pediatric orthopedic began as a Professor Salters Fellow in 1972 and continued until retiring from operating practice 2020. So in that 48 years of long career, he focused mainly on children's and young adult hip problems. During that time, he served as a surgeon-in-chief at a very famous hospital for sick children in Toronto, and also chair of the Department of Surgery in University of Toronto. His observation of these 5-decade practice that the treatment of DDH after 6 months of age has not much improved over these 5 decades. And why it has not improved, that we are going to discuss today during the interaction. We have another expert from UK, Andreas Roposch. He works at Great Ormond Street Hospital, and 20 years ago, he succeeded the practice of Mr. John David. He was also a fellow of Professor John Wedge. His clinical practice is again entirely on the hip problems. He has been a professor and head of the department for 10 years. He is currently leading a UK-wide randomized clinical trial on the diagnosis of DDH. He was a research chair of European Paediatric Orthopaedic Society as well as British Society of Children's Orthopaedic Surgery. We are very fortunate to have 4 faculty from India. The first is Dr. N Gupta. He is head of orthopedic unit at Government Medical College at Chandigarh. He served as a vice president of POSI, and he has a large number of cases of open reduction following DDH. Another expert from India is Alaric Aroojis. He is practicing in Mumbai and is attached to a famous Wadia Children's Hospital. He played a very active role in forming the Indian hip surveillance guideline for DDH and cerebral palsy. He is the current vice president of Pediatric Orthopedic Society of India. The Thomas Palocaren is head of pediatric orthopedic unit at Christian Medical College Hospital at Vellore. The Thomas also did a fellowship at Sick Kid Hospital when John Wedge was very active in his practice. The 4th faculty from India is Hitesh Shah, the head of pediatric orthopedics service at Manipal. In addition to active practice, he is a current treasurer of POSI. So that was a short introduction about our faculty. Now, a brief outline about our program. First of all, we will have a short presentation by Andreas, and he's going to speak about avascular necrosis following open reduction. And then we will have a discussion on the case. So we will have 4 to 5 cases, and those cases will be as a launching pad for starting the discussion. If you have any question, please ask me on WhatsApp number or on my text message on 97129 25600. I repeat, 97129 25600. So with that, I request Andreas to start his presentation. Over to you. Thank you.
Thank you so much for the introduction and for asking me to speak today. Before we start the case discussions, I will give a very brief talk on osteonecrosis secondary to DDH treatment, mostly reflecting some of the research that we have done so far. In the talk, I will cover how it is diagnosed osteonecrosis following DDH, what are the effects of osteonecrosis on function, such as hip function or quality of life, and how the relationship is between having osteonecrosis and acetabular remodeling of DDH. It is one of the most serious complications in DDH treatment. It is a main performance indicator for the quality of DDH treatment. And unfortunately, there is no treatment at the cause level of osteonecrosis. It typically leads to growth disturbance of the proximal femur. There is a typically poor acetabular remodeling and early onset osteoarthritis. It is a very common condition. This slide shows actually prevalence estimates of osteonecrosis, which range between 6% and 48%, as you can see here, wide range. The classical thinking is that there is a minimum of 2 to 5 years follow-up required in order to detect osteonecrosis. And some particular forms will not show before the age of 12 years. Often it goes along with a stiff hip. The premature osteoarthritis is inevitable, as I've said before, and the need for total hip replacement as early as in the 3rd decade of life for some of these cases. So this case shows you, this is a open reduction innominate osteotomy at 1.8 years, as you can see. At 7 years, you see already the changes of the proximal femur. And at 14 years, it turns out to be a type 3 osteonecrosis with a large credit trochanter and a very short femoral neck. So the different types as per radiography, there's different classification systems. We can diagnose it in infancy or in toddlers, as you can see here on the top left side. There is more established forms after skeletal maturity. There is a lateral fascial arrest, as you can see further down below, where the horizontal physis appears, or hypoplasia of the entire epiphysis, as in the bottom left image. Buchholz and Hodgkin have done a classification which is widely used. They define 4 different grades. So in type 1, there is a hypoplasia of the epiphysis. In type 2 is the typical horizontal growth plate with a lateral fascial arrest and the valgus deformity, which occurs over time. In type 3, there is a global vascular insult. There is a relative overgrowth of the credit trochanter and a very short femoral neck. And in type 4, there is a varus alignment resulting in a medial fascial arrest. We have done some work to grade radiographs according to these criteria. And as you can see here, there's a radiologist and there's 3 different surgeons, and they all graded the same X-rays. And you can see how much variability it is as they ascribed grades to different X-rays. The reliability was not very good. It was graded between fair to moderate, but not much better. And here again, the reliability estimates. Ideally, we want to be around somewhere 0.8, but as you can see here, these gradings were much lower, indicating it isn't easy to classify these different disease states and radiographs. I want to move on and ask the question, what does it mean for the patient to have osteonecrosis? There's a wide spectrum of clinical symptoms, such as no symptoms, limp difficulty walking, stiffness of the joint, pain originating from the back, the groin, the thigh has been described, knee pain, even buttock pain, or severe pain and back pain with an inability to walk. We did a study including 72 children with DDH and osteonecrosis at the mean age of 14 years, and we could show that the hip function and physical function was rather good. You can see here box plots that this is type 1, 2, 3, and 4 osteonecrosis according to Buchholz. And you can see that they are most of these children are shown here the medians very much on the top of the score, indicating normal physical function. Although there are some children who had affected poorer physical function. Similar was seen for the hip function, although hip function was more declined more in these patients. In particular, if one had grade 3 osteonecrosis, then the hip function deteriorated more. In another study, we investigated 149 children with DDH who had and did not have osteonecrosis, and they now were a mean age of 20 years old and up to 26 years old. And again, we could show that, hip function was actually rather good, as well as was physical function and quality of life between patients. So this is now the osteonecrosis, the dark one, and the lighter one are the non-osteonecrosis. You can see they are fairly much the same. These are all patients with DDH. And if you look into hip function by radiographic severity, again, these type 1, 2, 3, 4, you can again see that the type 2 osteonecrosis, this valgus hip, these children or these adults don't do so well. They have perhaps, the lowest hip function score that was observed. The last question I want to tackle briefly is, does osteonecrosis affect acetabular remodeling? Because it is DDH after all, and we want to see good and strong acetabular remodeling over time. So we did some research where we measured indices of acetabular remodeling, such as the acetabular index, the sharp acetabular angle, the superior centering ratio, and the lateral centering ratio, which are indicators of subluxation. And we have shown that the acetabular index so the osteonecrosis is the very dark line. The acetabular index is never as good as the acetabular index in children who have DDH but no osteonecrosis. It always lags behind, and the difference was significant. The same was shown for the sharp angle. So children who had osteonecrosis had a poorer acetabular remodeling in this respect as those who did only have DDH with no osteonecrosis. The same was seen actually for the lateral centering ratio. Normal values are above the red line, and these patients here, they are all below it. You can see that the normal values are below the red line, but the osteonecrosis patients, again, they are not as good as those who don't have osteonecrosis. And the same is seen for the superior centering ratio. So osteonecrosis does affect acetabular remodeling quite substantially. This is the end of my talk, and I'm happy to take any questions now or later when we discuss the cases. Thank you.
You're muted.
You're muted there.
Sorry, like we have a case based on avascular necrosis. So we will discuss all related questions at that particular point. So now I request Dr. Alaric to show his first case.
Thank you, Dhiren Bhai. Is my screen visible? Good. So I'm going to begin straight off the bat with a bit of a complex case that will leave most of us scratching our heads. But since we have two very experienced international faculty here and a few of my colleagues from India, I thought, why not begin with a little difficult case, since the topic was on complications of DDH. So we are obviously talking at a much higher level right now. So I'll present a case that is not very infrequent in our part of the world, where we see frequently children coming to us after the walking age. And the question here is that, how old is old? When would you put a stop and say, I don't further reconstruct the hip because this child is too old for a reconstruction? A small caveat is that this case was done many years ago by me when I had a lot more hair on my head and much less experience. So that's the only caveat I have right now for this case. This is a 10-year-old girl who presented to us with a very hyperlordotic and a severely waddling gait. She was quite incapacitated. Even at this young age, she was unable to walk long distances, definitely not able to play with her peers and partake in any form of aggressive physical activities. And the x-rays, as expected, showed bilateral high riding, untreated hip dislocations. There's a little bit of a grainy video. As I mentioned, this was done almost 15 years ago. So here's this girl, as you can see, who has no pain, but she gets a lot of fatigue, unable to walk more than a short distance, has this very severe waddling gait, and is unhappy, both the parents and the child, with the kind of gait that she has. I'll right away put up the x-rays. So here, as you can see, there's bilateral high riding hip dislocations. You can see there's quite extensive acetabular dysplasia. And looking at this picture and the clinical scenario, I'll open up to the panel and ask anyone who would like to volunteer for this case, what would you do? Would you leave this child alone? Would you attempt a reconstruction? Would you do some sort of a salvage procedure? So if there are any takers, I'll be grateful.
Yeah, Andreas, would you like to start the betting?
Yes, thank you. So what I can see is that the left hip actually appears to be slightly better than the right one. So what I'm looking for is at the acetabulum. I guess my key question would be, if this is a 10-year-old child and it's a bilateral dislocation, should one embark on any surgery at all? Given the results from Iowa, probably not, because these patients do reasonably well if it's a bilateral dislocation. So I would be very hesitant, but just for the sake of the exercise now, if we go into the radiographic analysis, bilateral high-riding dislocations and the acetabulum, the way I can see it is slightly better on the left side than it is on the right side. There's a significant widening of the teardrop figures, but there is no proper acetabulum that I believe is reconstructible on the right-hand side. And as for the left, I'm perhaps a bit more optimistic. But I guess, you know, age and laterality is, I guess, the key thing here, isn't it?
Sure, and I agree with that. I would say also, I think children like this need further investigations, at least in my hands. If I'm thinking or even contemplating of a reconstruction, I would always get some more imaging done, and you can decide whether an MRI or a CT scan or both. Here we chose to do a CT scan, and just to short circuit the discussion, I'll share the CT scan images. So that's a 3D reconstruction. If that is helpful to the faculty further to make any decisions based on this, I have these images put up for you as well.
Yeah, Alaric, can I chip in?
Yes, absolutely.
Yeah. So Alaric, for a successful outcome, even at this age, you require a round head, which this patient has, and you require a sort of a visible acetabulum, which I think on the CT has made the things a little more clear. So I would still attempt open reduction using the standard procedure of acetabulum, open reduction, acetabular procedure, as well as a femoral shortening.
Great, thank you. Any other opinions, Professor Wedge?
John, you're muted.
Yes, you know, the classic textbook teaching and the general consensus, you know, for examination purposes in North America is that you can expect reasonable results from treatment of bilateral dislocation until age of 5 and unilateral to age 9. Now, this has been modified over the years because of the better results in younger patients with a total hip replacement. The problem is that if you end up with one hip in and one hip out, you've made the patient worse. And if this hip were to redislocate postoperatively, it's more likely to redislocate on the right side because the acetabular development, as shown on the 3D reconstruction, is not as well developed as on the opposite side. So I would be very, very cautious. Now, the other problem that one gets after about age 10 is that you cannot predict which hips will have normal articular cartilage. The articular cartilage of the femoral head begins to atrophy somewhere between age 10 and 13. I have put a I've done bilateral dislocations with reasonable success in high posterior dislocations in children who are relatively undeveloped for their chronological age. But once you open the hip joint and you see obliterative necrosis, as I call it, of the articular cartilage of the femoral head, you know you're headed for a stiff hip postoperatively. So you need to exercise a lot of caution beyond 9 years of age and be very selective of which hips you choose for reconstruction at that time. And as I say, the result of a redislocation is worse than the natural history of bilateral dislocation. So you have to sort of invoke the principle of firstly, do no harm.
Thank you, sir. Those very prophetic words. I wish I had listened to this 14 years ago, but I didn't. So
Is an MRI a better option?
and
Alaric, 1 minute. I just wanted to ask us if MRI is a better modality to look at the cartilage than a 3D CT. John, what is your opinion on that?
Well, my thinking on that is that the CT scan, unfortunately, involves a lot of radiation for a 9, 10, 11, 12-year-old female. But it gives you a better, I think it gives you a better prognostic view. The MR scan shows the articular, but it depends on cuts. And of course, what we're looking at is we don't have the same advantage of the radiologists who are looking at this in much more detail than we are. So I found that practically speaking, CT scan is more valuable. I have seen some three-dimensional reconstructions with MR scans that unfortunately just don't show the bony anatomy as well as CT scans. So I tend to still favor CT scans.
John, would you do an additional MRI to evaluate the articular cartilage here?
Yes, I have done that on a number of occasions. I have not found a very good correlation between what I thought was poor, thin articular cartilage in the MR and what I actually found at surgery. So I think that there needs to be further refinement of MR scans with respect to our cartilage than we see with your typical community hospital MR scan.
Yeah, good. So I agree with Professor Wedge on this. For us, the investigation of choice at this age, especially when you're thinking of whether we need to reconstruct and how to reconstruct the acetabulum and where the deficiency actually lies, I think a CT scan gives you that much more information than an MRI does. Anyhow, to go ahead, this was the standard approach to the hip. We did a wide capsulotomy. And as you can see, when we opened up, the head, as expected, is a little oblong or ovoid. And we see that quite frequently when we treat older children because of the pressure of the femoral head against the acetabulum. So though it looks fairly round at times on the X-ray, as Professor Wedge rightly said, sometimes the cartilage might be deficient in some areas. It may be thinned out, or the head may be actually ovoid or oblong, which may not be well appreciated on the X-rays at times. The further thing we found, of course, is that the acetabulum, as expected, was dysplastic. And then as we had opened up, we were committed to go ahead and do an open reduction, to do a femoral varus derotation osteotomy. A few findings here, as I've already mentioned, that the head was a bit oblong and ovoid. We found that the neck was a bit short, and we could not get a really deep reduction that we wanted to. So that really necessitated doing a little more varus than what I would normally do. And these are the issues of treating this kind of patient at this age. Unfortunately, I don't have a longer follow-up of this child. But as you can see at a short follow-up, we spaced these reconstructions. We did first the right hip and then the left one. Surprisingly, the left one, where we actually thought the acetabulum was better, for some reason, the head did not reduce well enough inside the joint and it remained subluxated. The right one seemed to do a little better with the open reduction, the femoral procedure, and the acetabuloplasty. So as Professor Wedge very rightly pointed out, getting it right on both the sides is sometimes difficult for these bilateral dislocations. And once you go ahead and do one side, then you're committed to do the other side as well. With the interest of time, I'll move ahead very quickly for the last few slides.
Can I just interrupt and make
Yes.
one point? I completely agree with you about the interval between doing two sides. I think this is important. If you do one side and immobilize and then attempt to do the second side through, a half spica, then what happens typically is the first side redislocates in the postoperative period. And this takes all of one's ability, and it's very important that the mobilization not be prolonged, and that the first hip is seen to be well in the joint and likely to stay there, and make sure that the osteoporosis is somewhat improved by activity, and some range of motion has been restored before you move on to the second side.
Thank you. So I think we treat even hips at a younger age, the goals of the operative treatment will remain the same: to obtain a well-reduced and stable hip, to correct any residual acetabular dysplasia, and as much as possible to avoid complications of growth arrest and AVN. And the moot point really here is at till what age can one achieve all of these goals so that the hip that you put in is concentric, congruous, and stable. I'll just put up a few articles from literature. It's quite controversial even now. There are very few long-term studies. And I've just put a few of those studies that I have gone through. There have been a few more after this. But the upper age limit really varies between 6 to 15 years of age. And what goes side by side is what really is the natural history of unreduced DDH. And Professor Wedge has got some good experience with this. Here again, there are very few long-term studies, and the natural history very often varies by societal and cultural considerations, because what works in the West might be very different for children in low middle income countries where they need to squat or they need to sit cross-legged and they need to be much more active. If you look at various outcome measures and rating systems, most of them are weighted towards looking at the presence of severe pain and gross functional disturbance. And they tend to underestimate the true functional limitations that these children have. And again, as was pointed out by Professor Wedge, ultimately, I think the decision depends on two factors. Besides taking into account the social and cultural considerations, is it unilateral or bilateral? And as you rightly said, the upper limit from the textbook point of view is for bilateral will be around 5 years of age, whereas unilateral can go up to as much as 10 or probably even older. And again, I think the key point here will be the presence of a well-developed acetabulum, both the false and the true, to make a decision of leaving it out versus putting it in. So here are some papers on the natural history of unreduced DDH. Professor Wedge's paper is right up there, which talks of he had reported 42 hips where more than 60% had pain and disability. And what he found that if you have a well-developed false acetabulum, then the clinical result is in fact poorer, versus if you have a patient whose hips are riding up into the abductor muscles, where they don't have a true a false acetabulum, and then about half of these adults will still have a fairly good result. So I'll end this presentation now, and any final words of wisdom from Professor Wedge or from Andreas, I'll be happy to take. Thank you.
I think that's an excellent summary. I don't have any further comments.
Neither do I.
Okay, before we move on to the second case, let's ask our faculty. John, what is the oldest age where you have carried out open reduction for bilateral case?
Well, I guess I have to answer that question honestly. I had 13 years of age. And this is because the child was, for some reason, genuinely disabled. She couldn't walk a block, which is unlike most posterior dislocations. And I very carefully pointed out to the parents that really what this was the objective of this surgery was to have her hips function better for 4 to 5 years until her late teens, but she would be able to get through high school without much of a limp, and but inevitably osteoarthritis would set in, and that she would need a total hip arthroplasty in her early 20s. So it depends on the extent of disability, and I really felt this young lady had significant low back pain particularly, and was greatly functionally impaired. So I have done very few at that age. Hers was relatively successful. The X-rays at 18 looked remarkably good, but within 3 or 4 years, rapid osteoarthritis in the hip developed just as I had predicted.
Andreas, the quick number so that we can have opinion of everyone. Yeah,
Right,
the oldest age.
Most children that find me, they're unilateral dislocations, luckily. I guess the oldest was around 6, and by the time I did the second side, it was perhaps 6.5. This was a case where the acetabuli were really, really well preserved. There was a very good acetabulum on either side, and I felt there's a very good chance for this to be successful, and it was successful. Mm-hmm.
Yeah, Thomas.
So I don't do after 7 to 8 years of age. It's bilateral, unilateral up to 10, because I feel if you put it in and it causes more pain and disability than leaving it out in a bilateral.
Yeah, Alaric, you showed off 10. Anything beyond that have you done?
Yes, the oldest one that we did was 12, and that is part of what we had reported once in our IHDR paper. And that one was unilateral. So bilateral, I've become much more careful now. Unless I really see a good round head and a reconstructible acetabulum, then only I would suggest that. But I think once you burn your fingers a few times, you become a lot more careful about when do you suggest these very major surgeries for these older kids.
Yeah, Dr. N Gupta.
I have done, see, most of the children are not beyond 6, but I have done about 2 or 3 around the age of 10. They were actually having a lot of trouble walking.
Bilateral cases.
Yeah, bilateral, yes.
Okay, Hitesh.
But again, they were the ones with the round head and appreciable acetabulum on the radiographs.
Yeah, Hitesh.
Unilateral 13 years and bilateral 10 years. But bilateral, I am very selective.
Okay, good. So with that, we move on to the second case, and I request Dr. Gupta to show his case.
So, is my screen visible?
Yes.
Yeah, just
Yeah.
go to the full screen.
Yeah. So this was a 7-year-old girl, and something similar to what Alaric has shown. So this girl was really troubled. She's residing in a hill station, and she has trouble walking up and down, and she gets fatigued on walking even a few meters. So what we did was again a triple procedure of open reduction and shortening and a Degas. And if you see the immediate post-surgery on the right side, this is a bit of inferior reduction. So on table, what we saw was a good reduction, but it was a little bit inferior as we see on the post-surgery radiographs. But 6 weeks later, this is what happened. So there was a dislocation. The question is, we did a CT scan and it was a posterior dislocation. So my question is to the experts is, what are the factors which are responsible for posterior dislocation post open reduction? And the second question is, does a inferior dislocation predispose to a posterior dislocation? John?
Yes, this is a very, very interesting one. The inferior reduction, I think, may be perched on the posterior aspect of the acetabulum already. This is the problem, and the interpretation of X-rays are very, very difficult. Plain X-rays are very, very difficult. But I think the principal factor for a posterior dislocation post-reduction is you have to recall that in high posterior bilateral DDH, there is not much excessive anteversion. And the temptation is to always place external rotation in the osteotomy as well as varus. And then one typically, when they put it in a cast, internally rotates the leg to neutral. And this can result in the posterior dislocation. So I think you have to be very, very careful to immobilize these older children in relatively neutral rotation. There's also the phenomenon that the windlass effect of an osteotomy due to the tightness of the soft tissues. If you estimate that there's 20 degrees of excess anteversion, and you correct that for that whole 20 degrees, you will end up with lack or reduced reduced external rotation, because you always tend to overestimate. So I never, I generally only make a very careful of the intraoperative assessment of version. And if there is version to be corrected, I never correct more than the 40%. And then be careful not to internally rotate the femoral head, as people are prone to do following anterolateral open reduction. So those are my thoughts on that particular issue.
And John, if you have a little inferior reduction, as you see on your C-arm images, anything which you can do to improve that? Sometimes in the C-arm, you recognize on table, look, my head is seems to be going a little bit inferior. So any tips and tricks too? Yeah,
what I would do is I would look at the C-arm again by external rotation of the leg, to see if by externally rotating that whether it moves more superiorly, because the inferior reduction. The other point I make is that when for the amount of femoral shortening that you need to do is again less than the amount that you would estimate by reducing the femoral head after doing the femoral osteotomy, putting traction on the lower leg to see how much they overlap. That's classic teaching, and then remove that amount of femur. I perform that same maneuver, but I always subtract 1 centimeter from the amount that it would seem to be indicated to use. And then I think you'll find you have a little more tension rather than it being too slack, which also leads to the inferior reduction. So underestimate the amount of shortening to a certain degree.
Right. So, Dr. Andreas,
Yes.
redislocation is common after Salters and excessive derotation osteotomy.
Yes.
But do you see it frequently with the Degas and the derotation as well? And how much will you derotate actually?
Well, I would just echo what John Wedge has said. I'm very, very careful on a derotation and would assess it in an open reduction intraoperatively and tailor it to the patient, always leaving it good. And so you need to account for what the acetabuloplasty is going to do. And you need to estimate it. And once it's done, the acetabuloplasty or the innominate osteotomy, then one can check again because everything is still open. And if needed, one then needs to change the rotation. So maybe someone needs to then undo it and reverse it a bit. But it's very careful to overdo it, really. The rotation.
So how much would you derotate? How much would you leave the anteversion?
Well, I'd like to leave perhaps, if I can test it by an open reduction, then I'd like to understand what the femur is in relation to the corrected acetabulum. And I would like to see that with some good internal rotation, there is no posterior dislocation. So what you typically see is that there is an uncoverage of the femoral head once it's reduced, and internal rotation will then make the femoral head disappear in the acetabulum. But that should not be excessive, because then it goes too far posterior.
My rule is never more than 50% of the excessive version. So if you decide that given a normal version of 10 degrees of anteversion, if you would estimate it to be 30 degrees, 30 minus 10 equals 20, divide by 2, and I put in 10 to 15 degrees of derotation.
Mm.
Okay. So any particular reason you are not correcting to around 20 degrees or of the anteversion of the femur? Any particular reason for that? What is this number 50% like?
Well, what I'm saying is that in many instances, I will put it in 15 to 20 degrees, depending on the amount of rotation, but I only correct 50% of the excessive anteversion because of the windlass effect of the soft tissues reducing the total arc of rotation.
Okay.
And that means that you can then bring the leg to neutral rotation in the cast rather than having to leave it in external rotation to make it stable.
Yes, yes.
So how do you assess the version of the femur? Do you do it intraoperative? Do you do it pre-operative? And what is your method?
Both pre-op, I have with the 3D CT scan. I have an anteversion study as well, with cuts through the femoral condyles, and intraoperatively by putting my fingers on the most prominent medial lateral point of the distal femur, and then looking at the angle relative to that of the femoral neck and head.
So we use something like this. We put a wire in the center of the neck and we calculate it according to the femoral condyles on table.
Oh,
So
okay.
have you ever used this method?
Yes, I have used that method, and I've used it but I found that that there are problems with parallax doing that because of the angles are different. The thin pin up the femoral neck tends to go more anterior. The pins in the femoral side more posterior. And I went through a phase of using pins for this, but I eventually abandoned this because I didn't think it gave me much assistance in getting the correct amount of version for a stable hip.
All right. So what we did was we operated the other hip at 6 weeks when we discovered this dislocation, and we operated the redislocated side, the right side, at 4 months of the index surgery, corrected the version, and as Wedge said, that we give a cast in a little external rotation. And this is 1 year and 6 months of follow-up. Patient does have a little bit of coxa vara, and this is at 2 years following plate removal and distalization of GT.
Yep. Yes, I very much like the way that you've managed this patient, a very difficult one, and I think you've come up with quite a reasonable result. What I particularly like is the fact that I suppose about 15% of the time, put in a transfixion pin. Most of the reports are transfixion pins that go right through the center of the femoral head into the acetabulum. And as you know, and here is probably one of the good things about a spiky cast, there's always padding. The hip will probably move 10 to 15 degrees in any direction every time the child coughs or sneezes. And that will lead to a window washer effect. And there's only a small amount of articular cartilage in the femoral head and acetabulum. And so you can lose 15 or 20% of the articular cartilage surface because of this window washer effect of the movement of the transfixion pin that's intra-articular. So like you have done in this case, I placed the pin through the greater trochanter to just proximal to the lateral margin of the acetabulum. So I commend you for that.
John, one last question. Do you check the stability on table? And what is the method of checking the stability on table you use so that these sort of problems they do not occur? Do you do it prior to your capsulorrhaphy or do you do it after your capsulorrhaphy or at both the times?
I do it multiple times, and you have to be I check it once the hip has been reduced, whether and the femoral osteotomy fixed. I make sure that I will move in 20 degrees in any direction without redislocating. Following the capsulorrhaphy, I repeat that exercise to make sure, because one of the technical errors is to remove too much capsule and then to make the capsulorrhaphy too tight, forcing the femoral head out posteriorly. So I'm very careful to not. I use interrupted sutures. I make sure that it's not too tight, and then after the sutures, individual sutures have been placed, I grab hold of them, I tug on them a little bit, like they would be after the knot, and then I repeat the exercise of moving the femur through a gentle range of about 20 degrees of motion in every direction. And if it's stable, if you have to hold the leg precisely, or it will dislocate in one direction or another, then you know it's going to dislocate postoperatively. So the hip has to be, sometimes after I do these, I can flex the hip 40 degrees, I can externally rotate it 10 or 15, internally rotate it 10 or 15, adduct it about 10 degrees. You must make sure that it is completely stable on the table before closure and before applying the cast.
Gupta ji, can I ask you one question?
Yeah.
Soon after you found it inferiorly located on your IA images, did you do a CT post-op, limited CT, or did you do it 6 weeks later when you found it dislocated?
No, we did it at 6 weeks.
So you don't do one immediate post-op after the spike?
You really, if not, but in case, if you have a doubt, so we tend to do it in some of the cases because we are using the plaster of Paris cast.
Yeah.
Some of the cases where the femoral head was not visible adequately on the post-surgery X-rays in the spica.
Okay. Now, because
We do get in with a CT thinking that now the femoral head must be somewhere else rather than in the acetabulum.
as John said, when it's inferior, it's likely to be hinging on the posterior acetabular roof. So if you don't do an immediate post-CT, you may be missing a posterior dislocation.
Yeah, I agree. I did one very recently about last week where we found a situation similar. So I changed the spica cast again. This was done 2 days back. So one last question is for Andreas is, do you rely on the acetabular procedure, capsulorrhaphy, or both?
Both, actually. So some people don't do a capsulorrhaphy at all, which I always do. Of course, if you do the acetabulum, then you gain more stability in many hips.
I would add to that, I rely on the femoral osteotomy by still maintaining sufficient tension to aid with stability. And what I did in the last several years prior to my retirement, I was using a C-arm with 3D reconstructions that proved to be very effective in assessing whether the hip was stable or not, and avoided the excessive radiation of a postoperative CT scan done within 24 hours, which I always did prior to having the 3D C-arm. The problem with this, of course, with the 3D C-arm is for low-income countries, this is very impractical and expensive.
Thank you.
Thank you. Now we move on to the third case, Thomas.
Yeah. So as Andreas has said, mine is on, I'll go on to the one with avascular necrosis. And as Andreas said, it manifests much later. Can you see my screen?
Yes.
Yes.
Okay.
Please, yeah, full screen. Please go for the full screen mode.
1 minute. Okay. No, don't seem to be 1 minute.
Yeah, go to the slideshow and then the
Share. Okay, 1 minute.
no, just we are already
Yeah, I got
seeing it. Just go to the slideshow in the
Yeah,
top
I got it,
menu.
I got it,
Yeah.
I got it.
Yeah. From beginning.
Beginning.
Yeah. Okay, so I'll go on to a next another case. This is the first case, but a case which is another one on this case. See, this is a child, 1 year old, 1 year, 3-month-old child, post cesarean section breech presentation, which came with a limp, more on the right than on the left. So we went on to do an open reduction on the right side, and we did adductor tenotomy and closed reduction on the left side. This was the X-ray on the spica. And then following spica removal, at 4 years, we had to do a varus and a dega on the right side because it was the acetabular index was pretty steep. So the left seemed to be all right at 4 years. And then at around 9 years, this was the picture. With both horizontal physis and little valgus on both hips. So at 9 years of age, almost after 8 years of its initial presentation, we had this picture. So then we went on to do a bilateral varus on both sides, and we got a reasonable coverage. That is the story of this patient. John or Andreas, you have, do you want to go back to the initial ones when you want to, because the avian manifested quite late at around 9 years of age. Like Andreas had said, it can manifest quite late.
Yes, so for the in particular the type 2 AVN, so what you have shown, most of these cases do not show before the age of 9 years, and this is there's a very long, a big case series and long-term study from Stuart Weinstein on the topic, type 2 AVN.
Yeah.
Mm-hmm.
So I did John.
Yeah, could you move on to the next one, to the 9 year 9 year age?
Yeah.
See, one of the problems there, you probably with your postoperative, go to the next one. See what just doing a varus osteotomy like that, you haven't incorporated any medial offset, and that means that they've got the a wide space between the proximal femora but the femoral condyles are probably fairly close together, and she probably doesn't have a lot of abduction. So in that particular instance, I do either the different techniques, the Wagner or the Morsher double osteotomy, with by putting in the amount of varus and then transferring the greater trochanter laterally and placing it in the gap between the medial. And what I do is when I use the hip locking plate, as you have done on the left side, I put it through the transferred trochanter, as well as the even though you also need supplementary wires, and then you medially displace the distal fragment, of course, so that you end up with normal offset and a normal femoral head to a greater trochanteric distance.
Okay.
So I think that's it's a more complex osteotomy, but I think it gives a better result. This looks excellent because you've restored the appropriate anatomy, except for the lack of femoral offset, which is going to provide her with some functional, but I suppose mainly cosmetic problems.
Okay. I got some data on the avian, like as Andreas had said, there are both patient
Thomas,
factors. Yeah.
just a minute. Like I want to ask a question.
Okay, sure.
What about doing a screw physiolysis from inferior side to correct the valgus? John, what are your take on that?
There isn't sufficient growth to make a huge difference. That's at this point. And I think I haven't done that because the screw has to be placed perfectly, and you don't know exactly where the lateral fascial arrest is occurring. You'd have to know that to be able to accurately place the screw. I know it's a popular technique, but as I say, I moved almost exclusively in that particular situation. If there is not so much valgus that you have to make it into a very high trochanter, then I just do a normal femoral osteotomy. But if it looks like it's going to create excessive varus and a Trendelenburg limp, then I do the Morscher or Wagner osteotomy, double osteotomies.
So as Andreas had mentioned, there are the factors for avian is not well elucidated, but there are some patient factors like age, when you reduce or presence of an ossific nucleus, the grade of dislocation, and surgeon-related factors, the degree of abduction, pre-reduction traction, whether you do an adductotemy or not. And there's a recent study out of China which looked at close reduction after DDH, and they did around 140 hips, non-notate children. And they also had an avian rate of 31%. And they concluded that incidence of avian increased with the grade of dislocation and underdevelopment of the ossific nucleus.
Yes. Should I comment briefly on this?
Yeah, sure, please. Because you've done some work on.
Yes. So I guess what I meant to say in my presentation was, although we understand risk factors, we don't really know causal factors. We don't really know what causes it. That's not understood. So the mechanisms aren't understood. You have actually shown a few of these proposed risk factors, but none of them have really been validated strongly. So ossific nucleus definitely is known. There's meta-analysis, repeat meta-analysis on this one. There's no association. Grade of dislocation is somehow intuitive, isn't it? So the higher the dislocation, the more surgical exposure, perhaps. And
age. What about age? The older the age, is there more risk of avian, you think?
Yeah, some studies seem to suggest so, but don't forget, this is all observational research based on retrospective data. So there's no really good, prospective studies on it.
Okay. What about magnetic resonance? There are some papers which talk about MR perfusion for detecting avian earlier.
Yes. So this is work actually that originated from Boston. And my colleagues in Boston tell me they're still doing it, but it is not quite established yet, diffusion-weighted MRI. We have tried using it as well, but it's very difficult sometimes to interpret the diffusion-weighted MRI.
Okay.
And it's being used for children who receive a closed reduction and sometimes also for those who have an open reduction, but then it gets more complicated after a surgical exposure has been done.
Okay.
So I think it's perhaps, that there may be a value to come for the closed reduction children.
Okay. John, you have any comments on?
No, I don't have any comments on that.
Okay. So I'll stop sharing.
Yeah. Thank you. Before we move on to the next case, I would like to ask Andreas, you very well said that these are the probable factors which can lead to, but what are the factors or the causative factors? Why actually it happens? Because once we know that, then the next step will be on the prevention. So
yes. I think this is open for discussion, but I think it's not quite understood. I guess, one line of thinking is that a vascular injury. So vascular injury, so when the capsular dissection is being done and, dissecting around the femoral neck, the proximal femur, and it perhaps goes via vascular injury, hypoxia, and somehow it then leads to some vascular insult, bone insult around the physis, and then these fascial bars, they appear. as you can see them, for example, in the knee after a Salter-Harris fracture, for example. That seems to be the mechanism, some sort of injury that affects then osseous bar forming around the growth plate. But the bar doesn't necessarily have to be in a vertical angle. It could also be affecting parts of the growth plate. So one side, the lateral side in this case, is just not growing as fast as the other side, but there's diminished growth.
Yes, so these are the probable mechanisms. So what do you do at the time of surgery to avoid these complications or these possible mechanisms?
There's a very good paper John Wedge has written. So he commented on a paper.
Yeah.
Well, it's a very there just isn't adequate information to know that. But this is the problem with medial open reduction. The location of the approach, I think, inevitably affects the lateral physeal vessels. And if you look at results of medial open reduction with 2 to 5 year follow-up, the AVN rate is somewhere between 10 and 20%. But if you look, as with Weinstein, to skeletal maturity, it's up in the high 40s. So one of the this caused me to rethink my enthusiasm for medial open reduction, because it seemed that type 2, it was like flipping a coin, whether you get type 2 AVN or not. So I think that one has to be very, very cautious when approaching the because the original description that Weinstein did of this medial open reduction, he actually ligated the medial femoral circumflex artery, thinking that that wasn't really going to cause a problem. And there was a very beautiful, glossy series published 30 or 40 years ago of the technique. The problem is that kind of wide exposure probably inevitably damages at least a part of the circulation to the femoral head. So I've tended to move away from early medial open reduction to an extended closed reduction done through a medial incision, but simply carefully dissecting out the fibrous tissue around the capsule and releasing the iliopsoas. And in doing so, you can then move around from a more anterior aspect. And once you carefully remove the constricted parts of the capsule and the femoral head is reduced, then the medial the transverse acetabular ligament in the younger children doesn't seem to be a major obstruction. It's the iliopsoas, I think, that is the major culprit prior to 7 to 8 months of age.
I actually have a case of AVN after medial open reduction, but if we have time after Hitesh, I can show that.
Sure, yeah. Hitesh, please.
Yeah, thank you. Whether my screen is visible? Yeah, okay, thank you. Presenting the case, which is a 7.5-year-old patient not having any treatment. So we did not go for any CT scan, but we went with the open reduction, derotation, femoral shortening, and Dega osteotomy. So the hip was perioperatively quite stable. This is the X-ray after the 3 months. You can see that after the 1 year, it was behaving quite okay. The implant was removed. The child has been serially followed up for the 2 years. These are the X-rays. 9.5 years. Then this is the 3 years after the surgery, and this is the X-ray after the 4 years. So the child is exactly at 11.5. So my question to Dr. Wedge, in case of the older patient with such cases in follow-up, how will assess the acetabular dysplasia? And we can see clearly that the physis is getting the horizontal. So how can we manage?
Yep. Could you go back to the first X-ray? The pre-op. Yeah. You see, this is one of the worst, most difficult type to get a good result in. You notice that at 7.5 years, she's already getting a well-developed false acetabulum with cortication right opposite the femoral head. The proximal metaphysis of the femur and the medial aspect of the femoral head are flat already. So you know that whatever you do, and look at the very abbreviated medial to lateral length of the acetabulum. So you're working with an acetabulum here that is very deficient. And what you'll see when you open these up is that there is virtually no lateral acetabulum because it has been eroded as the femoral head exited the acetabulum. So this is not the typical ligamentous laxity type of dislocation that you see in a lot of the North American Aboriginal population or in the Northern European very lax jointed individuals. This type is often seen in South Asia and Mediterranean countries, and you have to be very, very careful about this. And I think you did everything you could to try to prevent this outcome. But I think that once it became evident that there was a major lateral physeal arrest, gross disturbance of the proximal femoral epiphysis, move up to your 3-year follow-up. Okay, right there. Oh, go back one. Okay, back one more. Okay, now forward one more. 3-year follow-up. Here's where I would have intervened, because you not only have a transverse acetabulum, that it is the physis is concave on its inferior surface, as you can see, and the acetabular dysplasia is recurring. And at this point, look at the U figure medially. It's still normal. It's not. It hasn't been. The teardrop has not been widened, but this is a somewhat unstable hip because of the valgus tilt of the femoral head. The load on the acetabulum is eccentric, and it's already starting to erode. So here's where I would intervene with a varus osteotomy and a repeat osteotomy of the periacetabular osteotomy. See, because when you go further, if you go to your next X-ray, still salvageable there. Go to the next one. This is the yeah. Now this is there was one more, I think, after that, was there not? Yeah, right there. At this point, the child is now 12 years of age. There's very little remodeling potential, and it's too late. Except, and if she's asymptomatic, then wish her well through her adolescence and education. And when she's finished her university, then she'll probably be ready for a hip replacement. But this is not retrievable at this point.
Okay.
If she's symptomatic, then one could consider a varus osteotomy of the proximal femur.
Okay. Would you consider the PAO when tridentine is not completely fused?
Pardon me?
The tridentine cartilage is not completely fused. Would you consider for the PAO or a triple?
Yeah, I would say so. What I mean by periacetabular is the pediatric version that extends to, but not across the tri. But it's. I'm glad you made that clarification.
Okay, thanks. Andrea, do you have any different thoughts, or would you agree?
No, I have nothing to add. I'd agree. You can see that, what I said before about the acetabulum, the remodeling is diminished by the osteonecrosis probably as well.
Okay. The Alaric, do you have any different thoughts?
No, not really. I think what you've done seems fairly good. And I think all these cases show signs of a type 2 AVN, and the underscores the importance of having long-term follow-ups in DDH right up till the end of growth. We have started using in the younger children the medial epiphysiodesis screw. I don't know how much it would actually work. There has been some interest in this around the world. And I agree, if the child is generally over the age of 8 or 9, it's less likely to work. But we have seen some of the younger children who develop a type 2 AVN where we have started using a medial epiphysiodesis screw. We're waiting to see what the long-term follow-up is. At least for the last 2 years, they seem to be holding out. They don't seem to be worsening in terms of the coxa valga. Maybe there is a role that it has to play, but I think there is some interest nowadays in that technique.
Thomas,
Yeah, I think it's important to. I mean, it's easy to be critical here, but you've done this young lady a great service. I mean, she's got a stable hip. She's going to have an optimal situation for her eventual total hip replacement. Remember, you started this at 7.5 years of age, and you've given her probably 15 years of excellent function until she needs her hip replacement. So I wouldn't regard this as a failure, but it just points out the limitations of doing this much later.
Yeah, this is 10 years after this the surgery. She is skeletally mature and she's totally asymptomatic.
Yeah.
So, and she is walking completely fine. So it's asymptomatic. So we can see the C angle is comparatively opposite side is less, but the head is also smaller compared to the opposite side.
Yeah.
So what would you rate as a head is smaller at maturity? There is no terminology for that. The AVN will have the bigger head, but in the literature, we don't have any terminology for the smaller femoral head.
Okay, well, I think that's an important observation, because it's the younger child that gets the big head with extensive AVN, but these older children, after about age 5, don't get coxa magna. They end up with small femoral heads, but as I say, these are hips that are not going to last a long time. They function well now. She's had great number of years since, and regard this as a success.
Okay. Any comment from Andrew?
I should say that hypoplasia of the epiphysis is indeed a sign of AVN as well. So it doesn't all. So hypoplasia is regarded as type 1, isn't it? Epiphyseal hypoplasia.
Yeah, but at end of the skeletal maturity, the width and the size of the femoral head is smaller compared to the opposite side. And
But that still goes with, I mean, this is perhaps, more like a type 2 AVN. This appears to be rather horizontal. But, there's mixed, often the distinction isn't that clear cut. So there are mixed versions.
Okay.
Mm-hmm.
That's fine. So I will move on. Yeah. Yeah, Thomas, anything?
No. I just said that is time for questions, or should I show the one with the medial open causing AVN?
Just a minute. I will just go for the second case.
Oh, you have one more.
It's just the 1.5-year-old kid with the bilateral DDH treated with a sequential open reduction, and that's 3 years follow-up. So it's you can see the both side. It's the valgus, and the left side is decentralized. What should you do?
But the left hip is also adducted. So
yeah, left is more. Yes.
So what you need to do is make sure that she's at an age now where you should be able to get a standing film, which is always more accurate in terms of determining the lateral migration associated with her bilateral type 2 AVN.
Yeah, we always take a standing. This is standing, actually.
Oh, really?
Yeah.
Mm-hmm.
But the left hip is still adducted, and that's exaggerating the amount of subluxation.
Yes. Andrea, you would like to comment?
I think also one needs to bear in mind is the anteversion, isn't it?
Yeah.
Mm-hmm.
Yes, the interrotation is more than the X-ray. It's antibiotic.
Yeah. So this hip may actually only look worse than it is. From
Yeah.
lateral views, when Rosen views may help.
We had it, but it is not in this presentation. So but
Mm.
it's homing well in the frog letter.
Mm-hmm.
And then in abduction and interrotation, it is also homing quite well.
Yes. There's as a double space on the left side, though, isn't there?
Yeah.
Yeah.
So we went and did the varus and the derotation on the left side. So it's in the follow-up where it's got its quite reasonable up to the 4 years. That's the left side is getting it a little better. It's at the 6 years we can see it's getting the tilted.
Yes.
So and when we counsel for the surgery, they were buying the times, and we can see in the 7 years, it's got subluxated as well as that lateral tilting. You can see the caput valgum. So the comment for the lateral tilting of the physis, the caput valgum, when we do about varus, there are higher chances of the recurrence. So it would be ideal to do about along with the varus, we need to do epipisodosis or isolated epipisodosis. It would be quite young. As Alaric suggested, we also started having the medial epipisodosis if we see about the caput valgum. Otherwise, that's the recurrence of the lateral tethering can lead to because of the growth arrest, and can lead to the lateral tilting. John.
Yes.
This is the last. We did it as Dr. Wedge was mentioning about the transfer of the trochanter along with the varus. The child is walking reasonably okay. This is the last follow-up X-ray. Any comment?
Yeah, well, I think that with the first varus osteotomy, the mechanics of the hip weren't completely restored because of the amount of varus and the configuration of the proximal femur. I really think that medial offset is important for how these hips function after the varus osteotomy. It's not enough to correct the varus. I think you need to realign the leg, because the mechanical performance of this hip will be impaired by that extraordinary curve of the proximal femur.
Okay, yeah, that's correct. Thanks, Thomas. You want to say something? You can go for your case.
Yeah. Before we move on, we have a question which is not directly related to the complications, but a very important practical question, and that is about the indications of acetabular procedures after open reduction. So open reduction, femoral shortening, and then the question is when to go for acetabular procedure and which acetabular procedure. That's the question. So let's start with Thomas first. Thomas, what are your views on that? We will go from Thomas to Alaric, then Andreas, and then last John.
So in the X-ray itself, the acetabular dysplasia is there by looking at the acetabular index. That gives you an idea. But generally, after the age of 2 or 3, it's better to do both at the same time. But if you do it less than 2 years and the bone is still cartilaginous, I sometimes wait till 3 or 4, and every sequential 6-month X-ray, the acetabulum doesn't develop, then I do a secondary Dega or a Salter.
Alaric, your take on that.
So the textbook answer was always, beyond the age of 3 years, and if the acetabular index is more than 30 degrees. But a lot of that is changing now, and I think even younger children are deserving of a pelvic procedure. So I think a lot of that decision-making process can be both pre-op and intraoperatively. So pre-operatively, if you see a lot of acetabular dysplasia, even in a younger child, even up to the age of 18 months or 2 years, I see there's no harm in going ahead with an acetabulopllasty. And intraoperatively also, once you've done an open reduction, my sequence is to do an open reduction. to see the kind of coverage that is there. If there's a femoral shortening which is required or some derotation, then I go ahead and proceed with a femoral procedure and then reassess to see the acetabular coverage then. And sometimes you have a good amount of acetabular cartilage which is present, though the bony acetabulum is not so good. So sometimes putting in a McDonald or a Jura retractor to assess the true coverage of the acetabulum over the femoral head is helpful. There are times where we've also covered the head with dye. You can do it even if the capsule is open because you get a better idea, or even sometimes on an air arthrogram with the true cartilage of the acetabulum. And if you find that it is dysplastic even after doing your femoral procedure, I don't hesitate even in a 1.5 or a 2-year-old to go ahead and do a pelvic procedure. The osteotomy of choice I follow nowadays has got varied names. It's called either the Albee procedure or the San Diego acetabuloplasty, which is what we tend to do nowadays. Thank you.
Yeah, thank you, Alaric. Andreas, your take on that.
I think the topic is a very wide one and difficult to capture now. I think the Toronto results, what Dr. Solter has done is rather convincing. There's a very long-term results on this open reduction and denominate osteotomy, which in my view should be the standard. And any deviation from this actually must be justified by good grounds, which is acetabulum morphology. And whether it's the primary or the secondary intervention, is it a repeat intervention. One thing I'd like to say though is that if there is osteonecrosis of the proximal femoral epiphysis, one needs to have a very close eye on the acetabulum and a very low threshold of intervening, in my view. And of course, the younger, the better. So there comes then, when the child is going to the age around 9 years or so, it's often too late then doing something because the remodeling potential is not there anymore.
Okay, then John, what are your views on that?
Okay, well, I generally, after somewhere between 16 and 18 months, I do an open reduction and a pelvic osteotomy. And the pelvic osteotomy I choose depends on the morphology of the acetabulum. In those where where it appears to be a malorientation of the acetabulum, I'll do a sulfur-nominated osteotomy. And where there is erosion of the lateral acetabulum, a steep slope, I will often do a modification of the original Pemberton procedure. You can call it whatever you like, Dega. I mean, the use of eponyms around about 2 square centimeters of human anatomy is ridiculous. I mean, their acetabuloplasties are incomplete periacetabular osteotomies, and I always tailor it to where the deficiency is. And then at somewhere between 2 and 3, depending on the height of the dislocation, I add a femoral shortening osteotomy. So that's generally my guidelines, the guidelines that I followed right up until the end of my operative career.
Thank you. Yeah, Hitesh, you have a question, please.
Dr. John Wedge, I have a question. I heard several times from sick kids is jumper type and sliding type. It's not been published. Can you throw light on that?
Yes, I will, because I think there are 2 different morphologies. I think there's genetic difference, and I tried to get this published, but the reviewers were not very kind to my description, because all of them really want to think that every DDH is the same, and one DDH is the same as the next one, and that if you develop a very standard procedure, that will work for everything. But it's not the truth. There is wide variation in the morphology of DDH, and this I always do business is not very constructive. So at any rate, what I learned after my first, I think it was within my first 100 open reductions and children over 3, I had a couple of redislocations. And I had moved from an area where the DDH was all in North American Aboriginals and people of Northern European stock. And I moved to Toronto with all of these South Asian immigrants and people from Mediterranean populations. And I had, I think, 2 out of 5, my first 2 redislocations. And I looked very carefully at these, and they were a completely different configuration. And so I started to look at these individuals. Those that have the jump dislocation are the classic, classic DDH due to ligamentous laxity, and with a strong family history, typically of great female predomination, whereas the slide dislocation is not associated with laxity. It can be associated with swaddling, and what it does is that the femoral head just doesn't jump out of the acetabulum, it gradually erodes, and these are the ones that are responsible for the inevitable miss rate of screening programs, because they often can't be identified in the first couple of months of life. And these ones require a different approach. They're probably a different genetic origin. So I think that there is a classic distinction between these two, but nobody ain't buying it from me.
Okay. We are coming to the end of the session, but before that, I would like to ask John, like during our email exchange, you mentioned that you have a regret in your long career that the treatment of DDH after 6 months of age has not improved over the past half century. So what are the reasons for that, and what do you suggest to the next next generation of orthopedic surgeons, what we need to do to improve the results and improve the outcome?
Okay, well, I have very strong feelings about that, which may be practical in some cultures and societies and may not be appropriate in others. First of all, you have to know what you're dealing with. You need to carefully assess what the pathology is for a particular DDH, because I think everybody, if you treat them all the same, you're going to have a very high dislocation rate. The second reason is that I was asked on numerous occasions to do quality assessments or to do a study on outcomes for a particular hospital where there were complaints about performance. And I think that this is very much volume dependent, the success with this surgery. And unless every pediatric orthopedic surgeon wants to do it, because in an open reduction in pelvic osteotomy is the index case for a pediatric orthopedic surgeon. But if you're only doing 1 or 2 cases a year, you're going to do more harm than good. I think that somewhere you need to do at least somewhere between 6 and 10, and preferably 20 a year, to become any good at this, and to be able to analyze each case individually and appropriately to have the right combination of procedures and the proper technical execution. Now, you may say that this is a little facile, because I'm sitting where over half of my cases were complications from other centers. That was the nature of the center, and I may have a skewed view of it, but every time I've gone into the community to assess that, I have found where a surgeon had a 40% redislocation rate in 20 cases done over 14 years. This is not the kind of surgery that you should be doing only once or twice a year. I really strongly recommend that hospitals get together, depending on their size and the local, maybe not very practical in others, but my view in Canada has been that there should be 6 centers in Canada doing open reductions after walking age. And then you would, and people say, well, that's totally impractical. Well, that's what they've done in cardiac surgery. We have 17 academic medical centers with pediatric departments and residencies, and only 4 in Canada do cardiac surgery. One fell aside one after another because of poor results. And I think we need to apply the same. And so if you want to do in big population like India with a lot of DDH, I think that centralization of procedures and designation within large hospitals of 1 or 2 people, and even in that situation, it's probably best that those 2 surgeons do most cases together. It's not a kind of case to start at 5 o'clock with a junior resident assisting you. So those are my my thoughts. They may be a bit elitist. They may be a bit inappropriate, but that's the conclusion I took away from why there hasn't been a substantial increase or improvement in the results of DDH over the last while. You know, there was a huge improvement when people recognized that by doing a gentle concentric reduction and avoiding the frog cast and avoiding rigid forms of mobilization for prolonged, that the AVN rate could be reduced. It was as high as 80% in closed reduction in the 1950s. But when Salter and several others came along and pointed out what the problem was, there was a tremendous increase in improvement of the treatment of DDH. But since then, there's been little progress, and I emphasize principally after walking age, which fortunately with screening programs now is not all that common, but it's still another imperative why these procedures should be centralized to specific units.
Yeah, thank you, John, for a wonderful sharing of your vast experience. So what you said is very right, that at this stage, we have a large number of cases who requires open reduction. But over a period of time, gradually, we need to have a better hip surveillance system in the country, and we should bring down the number of cases which requires open reduction. So with those words of optimism, I thank everyone for sharing their knowledge, sharing their wonderful cases. And I'm sure that from all these cases and the discussion, we will try to improve our surgical technique and improve our results. So thank you once again, and have a good time. Bye-bye.
Goodbye.